And next, let us discuss the diagnosis part. Now, in the diagnosis, the most common diagnostic test which is done, it is ultrasound. So, what is the most common diagnostic test? It is USG. And what will be the findings on ultrasound? It will show a double contoured membrane of the cyst wall. So, what will be the ultrasound findings? It will show a double contoured membrane of cyst, and also we can see a rosette of daughter cysts. Now next we can go for a CT scan, and what will be the appearance on CT scan? It will show a characteristic cartwheel appearance. So next we can do a CT scan. A CT scan, it will show a cartwheel pattern, and also it can show a multivesicular rosette pattern. After this, we can go for the various serology tests. Now next we can go for serology tests, and in this we have ELISA, indirect hemagglutination test, and immunoelectrophoresis. Immunoelectrophoresis, and please remember they have 95% sensitivity. Now these serological tests, they have 95% sensitivity. Now another important point is that the most specific, please remember this point, the most specific and diagnostic tests of hydatid disease, diagnostic test of hydatid disease, hydatid cyst of liver, it is detection of precipitation line, that is ARC5 on immunoelectrophoresis. So which is the most specific diagnostic test for detection of hydatid disease? It is detection of ARC5 precipitation line on immunoelectrophoresis. Now there is a important test which is termed as Cassoni's test. Now nowadays it has got only historical importance, and this Cassoni's test, it is basically what it is, an intradermal test having a sensitivity of 75%. So it is 75% sensitive. It is basically a complement fixation test, and nowadays it is only of historical importance. Historical importance. Now another important modality which can be done, it is MRI. Now this MRI, it is done if patient has jaundice. So if a patient has jaundice, we have to go for MRI, and in MRI what we can find the relation of this hydatid cyst with the biliary tree. So if the patient has jaundice, in order to visualize the biliary tree, and find out the relation to hydatid cyst, its relation to hydatid cyst. So we can say that MRI is used to see for any cystobiliary communication. So to see any cystobiliary communication, we have to go for MRI. Clear? Okay, next let us discuss the treatment part. Now first we will discuss about medical drug therapy. Medical drug therapy. Now let us discuss the indications of medical treatment first. Now indications are if 10 days, it is given 10 days before surgery, and to continue for 1 month in case of albendazole, or 3 months in case of mebendazole after surgery. So we have to give albendazole 10 days before surgery, and we have to continue this albendazole for at least 1 month after surgery, and for 3 months if mebendazole is given. Now another important indication is inoperable cyst. Inoperable cyst, we have to go for medical therapy. Then in cases of recurrent hydatid cyst, now if there are multiple cysts, or if there are cysts which are involving multiple organs, then in that case also we have to go for medical treatment. So if there are multiple cysts, or if multi-organ involvement is there, multi-organ involvement. Now in cyst of liver, of lung, if there are cysts in the lung, we have to go for medical treatment. And in cases of surgically unfit patients, if the patient is not fit for surgery, then you have to go for medical treatment in those cases. So in cases of surgically unfit patients. Clear? So these were the indications of medical treatment in a case of hydatid cyst. Now next, let us discuss the various contraindications of medical treatment. So next we will discuss about the contraindications. Now first is if there is a large cyst. Next, honeycomb cyst with septa. Then we have infected cyst, then calcified cyst. And please remember, in cases of pregnancy, the medical treatment, it is contraindicated. So in cases of pregnancy. Now let us discuss the various drugs which are used. So first we have albendazole. Now this albendazole, it is the most commonly used drug, and it is ovicidal as well as larvicidal. So it is ovicidal and larvicidal. Now what is the dose? The dose which is given, it is 10 mg per kg per day. Now it is given in 4-week cycle with 2 weeks drug-free intervals. 2 weeks drug-free intervals. And how many such cycles are given? 3 such cycles are given. 3 such cycles are given. So we have to give 4-week cycle with 2 weeks of drug-free interval. And how many such cycles? You have to give 3 such cycles are given. Now after that, what are the side effects of this drug? The side effects are alteration of liver function tests, then leukopenia. These are some of the important side effects which are frequently asked in exam. Then fever. And please remember that albendazole, it is contraindicated in pregnancy, and this was a recent question which was asked in the exam. Contraindicated in pregnancy. Now next important drug we have mebendazole. and it is given in the dosage of 600 milligrams daily for 4 weeks. So mebendazole is given in the dose of 600 milligrams daily for 4 weeks. After that, we have another important drug, which is praziquantel, and it is given in the dose of 60 milligram per kg with albendazole for 2 weeks. So it is given along with albendazole in a dose of 60 milligram per kg for 2 weeks. Now after that, there is an important procedure which is termed as PAIR. PAIR. Now it stands for puncture, aspiration, injection and re-aspiration. So PAIR, it is basically puncture, after that aspiration, then injection and re-aspiration. Now it has to be done under ultrasound or CT guidance. So it is to be done under ultrasound or CT guidance. Now how it is done? What we do under local anesthesia, the cyst is punctured. The cyst is punctured. After that, what we do, all the daughter cysts, they are aspirated. And then what we do, a scolicidal agent. A scolicidal agent is injected, and which is 2% hypertonic saline. Most commonly 2% hypertonic saline is injected into the cyst. After that, what we do, when we inject the hypertonic saline, we wait for a period of 20 minutes. So it is the contact time. So after that, after waiting for 20 minutes, re-aspiration is done. So after 20 minutes, what we do, re-aspiration is done. So if we see what we have done, we have punctured the cyst. After that, we have done the aspiration of all the daughter cysts. After that, we have injected the scolicidal agent, and then re-aspiration is done. So it is termed as PAIR, then PAIR. Now, what are the various scolicidal agents which can be used? Have a look. Scolicidal agents. Now we will discuss the various scolicidal agents which are used and their corresponding side effects. Now the first we can use is hypertonic saline. Hypertonic saline, and what is the side effect? It can cause hypernatremia. So hypertonic saline, it can cause hypernatremia. After that, we can use citrimide. Citrimide. Now what is the side effect of citrimide? It can cause acidosis. So it can cause acidosis. After that, we can use 80% alcohol. And what is the side effect of 80% alcohol? It has been seen that it causes cholangitis in majority of the patients. So it can cause cholangitis. Clear? After that, sodium hypochlorite. Sodium hypochlorite. Now the sodium hypochlorite, it also contains sodium, so there is risk of hypernatremia. Hypernatremia. After that, we can use hydrogen peroxide, or we can go for 10% povidone iodine. Clear? Now please remember one important point. In case of cystobiliary communication, we have to use 20% hypertonic saline only. Why? Because if we use other agents, it can cause cholangitis and fibrosis of the biliary tract. So in case of there is an important point that In case of cystobiliary communication, we have to use 20% hypertonic saline only. Hypertonic saline. Why? Because if other agents are used, it can lead to caustic sclerosing cholangitis. It is termed as caustic. Other agents will cause what? They will cause caustic sclerosing cholangitis. Now after that, let us discuss the indications of PAIR. So what are the indications of PAIR? So if there are cysts which are more than 5 centimeters in different liver segments, then we can go for this PAIR. So first indication is cyst more than 5 centimeter in different liver segments. Clear? After that, there are some patients which are not fit for surgery. So in inoperable patients, we can do PAIR. So next indication is inoperable patients. Now in patients with CL, CE1, CE2 and CE3 types, or you can say Garbi type 1 and type 2. In such patients, you can go for PAIR. Now in cases of infected cyst, so another indication is infected cyst. Now I told you that oral drugs, the medical drugs, they are contraindicated in pregnancy. So in pregnancy, this PAIR, it can be done. So another indication is pregnancy. And there is one more indication, that is children below 3 years of age. So these are the various indications of PAIR. Now let us discuss the contraindications. So what are the contraindications of PAIR? Contraindications. Now if there is an inaccessible cyst, that means we are not able to assess the cyst. In that cases we cannot go for PAIR. So first contraindication is inaccessible cyst. After that, if there are cysts with multiple septi or honeycomb cyst, in that case also PAIR cannot be done. So if there are cysts with multiple septa, that is honeycomb cyst. After that, hyperechogenic cyst. Clear? Now in case of calcified cyst, or if there is any cystobiliary communication, in that case also the PAIR is contraindicated. So in case of calcified cyst and in case of cystobiliary communication, Clear? Now there is one more contraindication. If there is cyst involving the lung, then also PAIR is contraindicated. So cyst in lung, so it is contraindicated. Now next, let us discuss the surgeries in a case of hydatid disease. So surgery. Now remember that surgery is the gold standard treatment in a case of hydatid cyst. So surgery, it is a gold standard treatment. Now how it is done? What we do? The abdomen is opened. After that, the peritoneal cavity. The peritoneal cavity, it is packed with colored mops. Why? Because these colices and daughter cysts, they are white in color. So in order to directly visualize them, we use colored mops. So what we do, the peritoneal cavity, they are packed with colored mops. After that, what we do, the fluid from the cyst is aspirated, and after aspiration we inject scolicidal agent into the cavity. And the most commonly used scolicidal agent which is used, it is normally hypertonic saline, that is 20% hypertonic saline with a contact period of 20 minutes. So which is the most common scolicidal agent? It is 20% hypertonic saline with a contact time of 20 minutes. Now I told you why other agents, colicidal agents, they are not used, because they can cause caustic sclerosing cholangitis. Now there is an important point, how we can diagnose this cystobiliary communication intraoperatively. Now what we do, we place hypertonic saline soaked white mops in the cyst. After that what we do, we gently squeeze the gallbladder. If there is bile staining of these white mops, that means there is a cystobiliary communication, and in that case we have to treat this cystobiliary communication. And how we do that? So next let us discuss what are the procedures to correct cystobiliary communication. Clear? Now first is suturing of the communication with the help of Vicryl or PDS, with placement of T-tube drain in bile duct. Clear? So first modality is what we can do, how we can treat this cystobiliary communication and obliterate the cavity. First is we can go for suturing with the help of Vicryl or PDS, and then we have to place a T-tube in the common bile duct. Now another important method is, it is termed as Perdomo procedure. Perdomo procedure. And what it includes? It includes placement of a multi-perforated transparenchymal drain into the fistula through the cyst, and another multi-perforated drain is placed into the cyst cavity. So first drain is placed into the fistula through the cyst, another drain it is placed into the cystic cavity, and a T-tube is placed in the bile duct. What is the aim of this Perdomo procedure? The aim is to achieve complete external drainage so as to facilitate the complete closure of the cavity. So what is the aim? Aim is to achieve complete external drainage so as to facilitate closure of cavity. Clear? Now after that, let us discuss the internal drainage procedures. So internal drainage procedures. Now these are the internal drainage procedures in case of cystobiliary communication. So first I told you suturing of the communication. Second I told you Perdomo technique. Another modality which can be used in cases of cystobiliary communication, it is internal drainage. So how this internal drainage is achieved? By choledochojejunectomy. Choledochojejunectomy. or we can go for Ru and Y hepaticojejunostomy. Clear? So internal drainage procedures, they include choledochojejunostomy or Ru and Y hepaticojejunostomy. Now, what are the other procedures which can be used in the treatment of hydatid cyst? So other procedures. So we have pericystectomy. Now in pericystectomy, what we do the peeling of the layer of the cyst wall, it is done. So what we do in pericystectomy, the peeling of the cyst wall is done. Peeling of the cyst wall. And after that, what we do, the abdomen is closed and a drain is placed. And nowadays, laparoscopic pericystectomy, it can also be done. Now, another modality which can be done is tube drainage of the cavity. Tube drainage of the cavity. Clear? Now, next important modality is capitonage. So what is capitonage? It is basically the spiral suturing of the cavity starting from the bottom, and we go above till the edges are reached. So in capitonage, what we do, it is spiral suturing of bottom of cavity and upward from base to edges of cyst wall. After that, there is another important procedure which is termed as introflexion. Now, what is introflexion? It is inverting the edges of the cyst without apposition. So, what is introflexion? It is inverting the rim of the cyst edge without apposition. Now there is one more procedure which is termed as omentoplasty. In that, what we do, we place the omentum within the cavity of the cyst. So another important procedure is omentoplasty. Clear? So these are the various treatment modalities in a case of hydatid cyst of liver. Now there is an important term which is called as malignant hydatid disease. Now, it is basically a misnomer because it is not a malignant condition, it is a benign condition. Now, the causative organism of this malignant hydatid cyst, it is Echinococcus multilocularis. Now, why it is called a malignant hydatid cyst? Because it resembles clinically and prognosis-wise to the malignancy. So that is why it is called as malignant hydatid cyst. In this, what happens? Whole of the liver, it is filled with multiple cysts. So next, let us discuss malignant hydatid cyst. The causative organism is Echinococcus multilocularis. In this, what happens? Whole of the liver, it is filled with multiple cysts. Clear? Now, I told you it is a misnomer. Why? Because it is a benign condition. Why it is called malignant hydatid cyst? Because it clinically and prognosis wise, it resembles malignancy. Now next